taper this morning for the first part, and I want to give a special thanks to Procter & Gamble, Vince Falcioni. Thank you for helping us to make that possible, and then also to Eric Frazier and Associates. Eric, appreciate your help in helping us to do that. The last group that I want to call attention to is really the group that's made this happen. I've had my years with tech and economic development things. I've worked with a lot of different folks and a lot of different boards, a lot of different groups. But I will tell you, I have never worked with a group that has been more professional and more passionate and more caring about what they're doing. This is a group that has served tirelessly and for no pay and no recognition. And I just want to call on members of the steering committee that have really helped us put this concept of employers like me together so that you'll know who they are, and during the day you can talk to them and tell them about what you think we might want to do in the future. And I'm just going to call their names, and if they would mind standing, and just stay standing for a few minutes here before we get everybody. The first is Barbara Barrett with the Langdale Company, Jamie Denton with Racetrack. Stand up, keep standing. Jamie, where are you? Jamie's already standing. Scott Barfield with Johnson & Johnson. Eric Frazier and Associates. Karen Fine with Georgia Tech MEP program. Vince Falcioni with Procter & Gamble. And someone who could be with us today who's played a key role, though, is Missy Jarrett with Chatham Steel. Keep Missy in your prayers today. Also, Gary Ross with the Savannah Business Group. Steve Rushing with Georgia Tech. Mary Eleanor Wickersham with the College of Coastal Georgia. And last but certainly not least, Mr. Mark Wilson with the Langdale Company. Let's get these folks up. Turn the podium over to Mark Wilson. Thanks, Don. Good morning.
Good morning.
Come on. It's been snowing, but that's exciting. Good morning.
Good morning.
I feel better passionate about our topics today. Look forward to exciting time of discussions on all different fronts. So it's an honor and privilege to be with you this morning. Before we go much further, I want to also follow up with what Don had just said. We need to give folks from Georgia Tech a round of applause for all they've done. They're great folks, and we've really been trying to, over the years, get something like this going, and been very thankful that we've come this far and just getting started. But as you know, the whole world of employee benefits, the landscape has been changing for several years, and probably in the last couple of years, a lot of new things are coming our way. So it's vital that the employer community continue to look at sustainable innovations and focus on benefit programs that are decent for our employees with good quality care coverage, but also that we have cost control techniques that keep our benefits plans affordable and sustainable. And I think that's a key word to stress this morning, as you'll see in the information we're looking for in our different topics. Sustainability is going to be a vital piece of what we're talking about this morning, that we're looking at long-term solutions. And with our company being in business for many years, we're very fortunate to be able to look at the long-term process of healthcare innovation. But anything from healthcare coverage issues to cost containment has been in our realm. But in the last several years, the employer community has been fragmented. It's a lot like the whole healthcare system as a whole. We're typically in silos, working here and there, and we often don't just get ourselves together on a regular basis to build relationships and look at innovative solutions. So throughout the last several years, there's been a number of efforts, pockets of employers, if you will, of course in Savannah and Albany and Valdosta, and of course here in Atlanta and different areas of the state. But we've never been able to get quite to this level where we have the whole state employer system together, working hand in hand with the other stakeholders in the whole healthcare system. It's truly a mission of collaboration. So finally now, thanks to Georgia Tech's efforts to help us to get better organized, we're now trying to share the best practices of innovation and cost containment that's out there so that we can be good stewards of our health plans. And so that's the whole essence of what we're doing, is learning from our peer-to-peer process of education that really you have in all other stakeholder groups when you think about it, the hospitals, the physicians, insurance community, all the different stakeholders really have their own peer-to-peer learning process. So we're pleased and honored to get our process going as well. Something you'll be seeing in a few minutes is we have a very exciting piece that over the years we've collected the best and brightest concepts and successful techniques and put it together in what you'll see is an innovation roadmap, if you will, or an overview of how employers have pieced together the whole process. And say the second concept, or the second piece, if you will, is plan design. We need a blueprint. Once your management team is brought up to speed, we need a plan design process. There's several subtopics there, from understanding the corporate culture that exists to make sure whatever's designed fits within that strategy, a comprehensive, proactive approach. Many of our programs over the years were reactive in nature because largely the healthcare system has been reactionary until just the last few years, where now it's a balance of well care and sick care at the same time. Data-driven is a big part of what the process there in plan design entails. The vendor-partner integration, provider competition and quality, education communication, and then an ongoing analytics or evaluation process. And finally, the third piece you'll see as we go forward is the program implementation. Once you have your plan design laid out, then it's time to get down to the nitty-gritty to put your program into place, from educating and engaging your employees, prevention, wellness, disease management, looking at treatment, value-based providers, and centers of excellence, just as some highlights. But this is more.
I was asked to introduce Brian. I've known Brian for about 8 or 9 years. He's a very special person. Often we've heard that you really don't care how much somebody knows until you know how much they care. And one thing you can say about Brian is he cares and he has the passion. He has the passion to do the right thing for the right reason, for the right outcomes.
Good morning.
Good morning.
I'm going to try to move real fast. There's a lot that I want to convey to you, but over the last 8 months or so, I've done about, 10 talks around to large groups of employers in different communities around the country, and I'm getting better and better at it. But the theme is the same, and I'm going to walk you through this. And it's how basically the healthcare industry is pulling the U.S. economy off a cliff. And I'm going to show you the numbers to demonstrate that, and then we're going to talk about ways that functional ways that we can mobilize. Mobilization is the hardest part because nobody really wants to do that. Everybody, it's being if you're in the lumber products business, that's a different focus than working on healthcare. But the larger context is what's important here. I'm doing a bunch of work right now in a town called Eau Claire, Wisconsin, where the average cost per employee is $19,200. There are, in this community with 75,000 people, there are 4 major health systems, and they're literally draining all the money that's available from that community. When we had an employer meeting, somewhere around 20,000 employers representing about 20,000 of the local inhabitants showed up at the meeting, which is an enormous, a quarter of the population. And the CEOs that I talked to said, well, we get great care here. I mean, there's Mayo and Marshfield and some other groups. We get great care here, but the costs are just crushing us. They understand that healthcare is the overarching problem in the country, and nobody knows what to do about it. This is a slide that I like to show at the beginning. This is from a buddy of mine who I consider to be the rock star of medical management in the country, a guy named Jerry Reeves in Vegas. Jerry developed this slide when he was running the Culinary Fund health plan in Vegas, which had about 310,000 lives in it. And what it shows is that you can go into any market, Atlanta, you can pick any condition, heart attack, and the specialists that deal with that condition. So let's say cardiologist in this case. You make an assumption that all the doctors are equal in quality, and then you look at their episodic costs meaning the cost from the time the patient presented till the time the issue was resolved. You look at the episodic costs across all of those doctors for that condition, and what you'll see is that there's one guy who consistently does it for the equivalent of $1, and there'll be another guy who consistently does it for $8, and then everybody else falls in between. And that is such an overwhelming problem because many employers that I talk to, they think that if you go to a doctor, he does the same thing to you that any other doctor would do for your thing. And it turns out that's just not true. So how bad is it? What the cartoon says is you've got all these lemmings, and one of the lemmings is saying, well, I'd like to question the leadership on this move, but healthcare is destroying not only the American dream of individuals in the country, but it is dangerously out of control at a national level for the economy, and that's what I'll show you. Here's PricewaterhouseCoopers. The study was led by a guy at Intermountain Healthcare in Salt Lake, and what it found was that 54.5%. This is always a guess, but 54.5% of all of the money that we spend in healthcare provides absolutely zero value. On a base of $2.8 trillion a year now, you're talking somewhere north of about $1.6 trillion a year. Put that in perspective. Keep in mind that, remember when the Congressional Supercommittee about a year ago came together and they said, oh, we're going to find $1.2 trillion over 10 years, and they failed. We're blowing that every year on health care, providing no value, and it is draining the national economy. This number that I'm talking about is bigger than our national budget deficit last year. So it is a huge, huge amount. And what this slide shows is questions about who's got the best quality, the best health care in the world, all that nonsense aside. We have the lowest value health care in the world. If value is cost into quality, we have the lowest value health care. And that is an important point. Here's the Milliman Medical Index, which shows last year that we were at 21 grand for any family of 4 across the board. Now that number includes the employee contribution, the employer contribution, and the employee out of pocket. This is a number that's going up very, very rapidly. They've been tracking it for a long time, but it shows the magnitude of the problem. And the net result of this is that we're getting a lot of people who are losing coverage. Now that'll change next year, but one of the critical indicators of the health of the system is to look at how fast people are disenrolling from health coverage. These are not people who have always been uninsured. These are people who always have been insured, and now they're losing the coverage, meaning that they're not going to stop needing care. It's just, they don't have a financing mechanism anymore except their own self-pay. So it shows that in the last decade and now, $4 out of every $5 in all household economic growth is all being siphoned off by healthcare. This is an astonishing figure. It means that $1 in every 5 of economic gain by households is available for stuff other than healthcare. The stuff that doesn't matter, like education and buying retail and energy and everything, groceries, all of that. That's how serious the problem is. And then this slide shows that when you take the national budget and you look at it over time, and you take everything but healthcare, everything stays flat. But when you add healthcare, that's where all the growth in the economy is. Paul Krugman was on CNBC about 3 or 4 months ago having some combative discussion. And whatever you think of Krugman's politics, he's a liberal guy who writes for the New York Times, but he did happen to win the Nobel Prize for economics. And what he said was, if tomorrow America had France's per capita healthcare costs rather than our per capita healthcare costs, all of our national physical problems would disappear overnight. And that is true. So this is the slide that demonstrates that it's all healthcare. Now here's the slide that shows that since the recession began, 45% of all the new jobs have been in healthcare. So it means that while everybody else has suffered tremendously, we've been supporting the healthcare industry's continued growth even through these most dire times. Healthcare is just way higher than everybody else's, and that's contributing to it. So in other words, our workforce is not as healthy as everybody else's workforce, and our productivity has declined. So here we have the pricing problem shown internationally. So look at an MRI. So average cost for an MRI, these data are about 2 years old. Average cost for an MRI in Britain is less than $200. Here it's $1,009. To give you an idea of this, in my clinic company in Lafayette, Indiana, we're buying MRIs with a reading for $450 a pop, and I'm doing 110 of them a month. All of our clients, Subaru, Fairfield Manufacturing, and so on, Caterpillar, they had previously been paying between $1,750 and $3,200 on their plan, which means that the plan wasn't doing a thing to get best pricing. The plan was simply passing the cost through. This is part of the problem. So what we see here is that on stenting, for every one stent that's installed and they get better outcomes, in the UK, New Zealand, or Switzerland, we're doing more than 4. And that's because if I put in a stent and I'm an interventional cardiologist, I'm going to get $1,200, $1,300 a pop for them. That financial incentive does not exist in those other countries. They're more interested in just what the patient needs. The same thing with MRIs. Look at France, the UK, and Australia. At about 5, and we're more than 5 times that in the U.S. for the same thing. What are the structural supports of this? One of the issues that we're dealing with I'm an owner in what I would like to believe is the very leading edge clinic company. We do not think of ourselves as a primary care organization. We think of ourselves as a medical management organization, and the underlying thesis of that is that primary care is really important. I'm going to get to that again in a minute. Primary care is really important, but the cost drivers of healthcare it's a multi-headed monster. And if you're going to be effective at controlling costs, you have to develop multi-vectored solutions. We're allowing this in the country because of lobbying. You have lack of patient engagement. So people have conditions, they're just, they have the dry cleaner approach to their own health care. I'm going to drop my body off and you take care of it and I'll come back and pick it up later. Then you've got all kinds of misaligned incentives in the benefit design, which work to the benefit of the health plans and the health care providers, but not to the guy paying the bill. We'll address that in a moment. And then on top of all of that, then you just got flat out bad luck. Somebody gets into a car accident or things go south inside a hospital system or whatever. The second thing is fee-for-service reimbursement, which we all are very familiar with. Fee-for-service incentivizes doing unnecessary services, because if I'm getting paid for everything I do, I'm going to do a lot of those things quite independently of appropriateness. And we know that very well. The third thing is a lack of quality, safety, and cost transparency. We can't identify what things cost. We can't identify who does a good job and who's lousy. And so all comers get equal treatment. In my clinics, by the way, people come to the clinic for nothing. They pay nothing to use the clinic. And if they use the clinic, they get all their drugs, their labs, and their x-rays for free. These are huge inducements that a lot of people think are a lot of people, meaning, by the way, the consulting community, the broker consulting community, think are stupid, because if you just let people have healthcare for free, then they'll abuse it, as though people want to come to go see the doctor in general. There are some pathologies that fall into that category, but not in general. So the name of the game here is getting people into the clinic so that you can engage them, You can manage them, and you can advocate for them anywhere in the system. If you knock down all the barriers to primary care access, then you've got traction over the rest of the system where the real money is. That's our logic. And it turns out that it works. In every single one of our clinics, we've gotten over 60% of the employees and 50% of the eligible dependents into the clinic in the first year, and that's why we're able to get traction over larger healthcare costs. So this thing of out-of-pocket costs is really, really matters. I'm going to give you another example in a minute from my buddy Jerry Reeves. No healthcare, no IT interoperability, unnecessary complexity. Any of you who've received a hospital bill in the last 5 years know that it's utterly inscrutable, and Yellow Pages networks without any regard for whether people are any good or not. They are vendors taking public dollars. We are not allowed to have information about their data. Those data are locked, and despite its promises, the Obama administration has not unlocked it. So if you want to know who delivers a pizza the fastest in town, you can get that information. Or you want to know who to have work on your car, you can do that. If you want to know, if you have a sick child and you want to make sure that you've got a best shot of getting her off the table alive, you don't know which doctor to go to because there's no way to find that point. This was a study that came out last year, and it showed that patients who went into 180 different hospitals in California, that there was a 122 times difference between the least and the most expensive patient charges for the exact same procedure. And let me point out here that all outliers were removed from this study. So they only looked at patients with emergency appendectomies that were in the hospital for 3 days or less. Over the last 20 years, CMS and HCFA have accepted, without further due diligence, almost 90% of all of the recommendations from this group with no further due diligence. So the net result of this is that this is essentially a lobbying group. Their proceedings are not open to the public. You can only be invited by the chair to one of their meetings, and if you get invited, you have to sign a non-disclosure agreement that says you can't talk about anything that happened at the meeting. They use shoddy scientific methods. So if they're doing a survey of their members, of their orthopedists, to find out what their orthopedists think the resources required to do a certain procedure are, if 30 of the orthopedists in the country respond to that survey, they'll use that as the guide. And the orthopedists know that what they put down on the survey will influence the payment that they get. This goes on, but the larger message is that this is the beating heart of the American healthcare cost crisis. This is the thing that over time has driven up, it has overvalued specialty care dramatically. It's undervalued primary care. It has inhibited primary care's ability to hold specialty care accountable, because now primary care doctors have an average of 8 to 10 minutes in an office visit. They're like gerbils on a wheel. 25 years ago they had 20 to 30 minutes. So they don't have the time now to pick up the phone and call a specialist and hold them accountable. It has created tremendously lucrative financial incentives for specialists to do procedures that many times are not appropriate. And then it has created a disincentive to go into primary care, because the average primary care doctor is going to make $3.5 million less over the next 30 years than their specialist counterparts. They're going to make 10 and a half. The most compelling thing to you personally is going to be market-based solutions. And please keep in mind that my company is a market-based solution, and I get that. And we're all about that in spades, but ultimately that's not enough. And so over the last 20 years, the healthcare industry has come to employers and said, here are the things that you should do. You should let's create better steerage to certain doctors and certain people, that we have better better discounts with than other facilities. Almost all health plans buy stakes in pharmacy benefit management companies, jack up the pricing 200 to 250% on generic drugs, and then use the profits as a revenue stream, and then tell their clients that they're managing their costs. Because we're buying generic drugs from a company out of California called DSI, and we buy them at about 40% of what our clients are currently paying for them on their own health plan. And we're passing those costs through directly. The health plans are capable of buying them what we're capable of buying them for, but they don't because it provides them an additional revenue stream. That's the kind of nonsense that you're dealing with. Wellness, disease management, lifestyle coaching programs. There's a lot of data now that show that in general, while this particular thing that I just mentioned is the darling of corporations, it produces almost no savings ever. The guy who is generally billed as the father of disease management, Al Lewis, who's a very witty guy, just wrote a book called Why Nobody Believes the Numbers that shows that there's almost no savings in this area. Is it important? Yes. What wellness and prevention programs end up doing is prevent people from becoming sicker over time. It prevents well people from becoming chronics from becoming train wrecks. Does it save a lot of money short term? Absolutely not. But you got to do it. So, let's lay that to rest. Incentives, I'll talk about that in a second. Renegotiated network discounts, fine. Save 3%, 4%, maybe. It's not going to save you 20%. And giving employees more skin in the game. That is benefits talk for put the risk off on the employees. As you saw in that earlier slide, we haven't managed the care process, and that's where the money is. Service reimbursement, by definition, promotes unnecessary care. Medical homes are about providing appropriate care, QED. End of discussion. That's part of the problem. So there are all these organizations in the country that have gotten level 2 and level 3 medical home status, which conveys to you, the purchasers, that they've got something special that they're adhering to, yet they don't really. And there is no data, none, zero so far, that shows that medical homes consistently produce quality improvement or reduction in cost. That's a real problem. So, in other words, this is another area where purchasers are being handed a bill of goods. That doesn't mean they can't be effective. They can. Ours are. But we adhere to a different set of rules, and we're very aggressive. But you should be very wary of when somebody says this. The second thing that we have done is we're very aggressive on full continuum management of clinical, financial, and administrative risks, and I want to show you what I mean by that. Ensuring the appropriateness of necessary care. Once somebody gets into the hospital, all bets are off, unless you have somebody riding herd. The single biggest area of healthcare cost growth is inpatient care, especially for the most serious patients. PricewaterhouseCoopers and Munich Re released data last year showing that the percentage of patients that are going over $1 million has increased 7-fold in the last decade. And acquiring high-value products and services more cost-effectively. This is the MRI example. This is the drug example. We're doing this with ambulatory surgery, with pain management. Pain management is a real issue for everybody. With PT, on and on and on. Healthcare is a big place. If you're interested in getting market-based pricing, which is volume-based, rather than simply getting whatever the health plan says that they'll do for you, you can save tremendous amounts of money. All of you undoubtedly are familiar with what Walmart just did. For those of you who aren't, because you may have left the planet that week, Walmart just cut a deal with 6 health centers around the country so that if you need spinal surgery, heart surgery, or a transplant, they will pay for you and your companion or spouse to go there, no cost to you, and then they'll effect continuity of care when you get back home. They cut deals with Mayo, Geisinger, Cleveland, Scott and White, Virginia Mason, and Mercy Springfield, which is closest to Bentonville, Arkansas. So what they did was they looked at the performance numbers on all these facilities. They cut a deal with them on the price. All of the facilities agreed to have transparent pricing, and they'd give them all the data to exchange their treatment guidelines, and so they're sending all of them there. If I were a local hospital, I would be freaked out because they just cut seriously into their revenue stream. The woman who engineered this is at a company called Health Designs Plus in Cleveland. She's the one who's working with Walmart on this. And then care gap analyses, this is huge. When we do care gap analyses, 350 of them are embedded in our EMR. So if a patient walks in who is, say, a diabetic and hasn't had an A1C in the last 6 months, an alert goes up on the screen for the doctor and says, give this patient a hemoglobin A1C today, and so on. Analytics of provider performance. Who's a good doctor, who's lousy, who has high episodic costs, who doesn't. Data collaboratives. There's all kinds of contractual language that your plan is probably receiving from Aetna or United or the Blues or whoever, saying, oh no, if we give you your data back, you're not allowed to analyze it to figure out who's a good and bad doctor. You need to challenge that, and you need to get together with other people to challenge that. That would be a good thing for a new collaborative to do right out of the gate. Challenge it legally, because it's your money that's at risk. Because lobbying is a matter of who has the biggest gun. And while the healthcare industry is the largest single economic sector and by far the richest sector, there's only one group that's more powerful, and that's everybody else who's not in healthcare. So that means healthcare is now a fifth of the economy. It's a tenth of all the jobs. And so far, there's been no successful effort to meaningfully mobilize. And many organizations just are running away. They go, I can't deal with this. I've got to run my business. So this is a real problem for the country because the implications, as I showed earlier, are so dramatic. So that means that there's only one solution from my point of view, and I'm not at all, optimistic that we'll get there, but my job is to throw it out there and say, I really, really hope that it starts here in a meaningful way. That's collaborate. You can collaborate for strength and for scale, and you can do that here. You have wonderful resources in this room. First of all, you've got the Savannah Business Group, which is one of the best organized and most effective business health coalitions in the country, probably the smartest business health coalition in the country. And you should work with them, with what's going on in Charleston, with getting together stuff that's going on here, all come together and get more strength. There's stuff, keep in mind that when the healthcare industry gives $1.2 billion to Congress, there's nobody on the other side who's going, wait a minute, let's not do that, because the healthcare industry has given the money and just goes in there and gets its way. So there has to be a monitoring process and a response action that's more powerful, because Congress has made it clear that they will respond to whoever gives them the most money. This is a parting shot. Several years ago, Rick Scott, who's now the governor of Florida, came and sat in my living room, and it was him and me for about 5 hours, and we talked about his experience at HCA, where he founded a company called Columbia, which merged with Hospital Corporation of America. He was elegantly dressed. He was extremely articulate. I'm not a personal fan of his politics, but that's neither here nor there. He ran HCA, and he was one of the driving forces that made it into what it is today. And this is a quote that he came up with about 4 months ago that I became familiar with. And I sort of think this is the horse's mouth right here. Like, this is why the healthcare industry is not going to fix the healthcare industry, because nobody wants to take half of the money that they're currently making. We need to like appreciate this. This is the message. Only you can say this. That's the point. Only you. And I really, really hope that you will come together and that you will make this into an effective, powerful effort, because it is more important than you can possibly